So I'm Ted Michaels. I'm the co-director of the Professional Development Core for the NIGMS-funded Great Plains IDeA-CTR. And it's a real pleasure today to introduce Dr. David Kaelber, who's been kind enough to come and join us from Case Western University. David is a practicing internist and pediatrician, and he serves as the Chief Health Informatics Officer and Vice President of Health Informatics and Patient Engagement Technologies at the Metro Health System at Case Western. So it was good that he had all those credentials because he was able to get his talk pulled up very smoothly. So because I couldn't help him. David began his informatics leadership at Metro Health in 2008, and he is board certified in clinical informatics. He's here today, and the timing is really exquisite. So David has substantial expertise in examining real world data using platforms like Cosmos, the Epic platform, but also Trinetics. And the timing is perfect because UNMC, and many of you likely saw the email late last week, that Trinetics is coming on board, is on board actually as of last week. Our Ready Core, here at UNMC is managing that, but if you go to their site, it's so new that I don't think right now you'll find anything about Trinetics on the site. But you can sign up. Jared Anzalone is here, who is a contact for that in the Ready Core. You can sign up for that. There is a training requirement, Jared was telling me, that's on Canvas that people will have to complete. And I think you're going to learn today from David just how powerful data sets like Trinetics can be to ask real world clinical questions that matter. So David, again, big thanks for coming here, and I appreciate you being willing to share with us.
Excellent. Well, very wonderful to be here. Can everyone hear me okay? Just switching microphones here. Okay, excellent. So yeah, very excited to have the opportunity to talk to you all here. I was telling some of the people I was meeting with this morning. This is my first visit to Nebraska, but so far maybe it won't be my last visit. I would love to really, develop some partnerships here. I think one of the amazing things about some of these electronic tools is literally as long as you have internet connection, you can use these tools. So I have partnerships with other people around the country, and would love to add some people either in the room or online to that list. What I hope to be talking about here is really using electronic health records for scientific discovery. And most of this will be talking about the data in the electronic health records and how to do that. And to me, this has been totally transformational to my career. And hopefully I can plant some of these seeds with you all as well. So my learning objectives, just a little bit to define and describe the opportunity for electronic health records for scientific discovery. And again, I think hopefully by the end, I'll show you that it's really now is the time. I think, until the last couple of years, the infrastructure and the data and the tools just wasn't available. So literally, we are the first generation of people in clinical medicine that can really start to leverage these tools. So that'll be one. Then really spend a bunch of time digging into Slice or Dice or Cosmos, which is sort of like the Epic tool for a lot of this, which my understanding is all the healthcare systems have. And then also spending some time on Trinetics and a lot of times I guess the question like, well, do we need both? Like, why do we need to have both? Right, especially from the leadership. And I would say, hopefully, again, by the end, I'll convince you that there's a little bit of overlap, but there really are some significant differences in the tool where one tool is going to be good for certain sets of things, another tool is going to be good for another set of things. And then, I always try to inspire people to say, you are taking 55 or 60 minutes of your life to listen to me. So hopefully there's at least one thing that you will do differently after this talk than before the beginning. I don't know what that is yet, but think about this talk. What are you going to be doing differently after the talk? I have no conflicts of interest to disclose, no financial relationships with either Epic or Trinetics. But a huge part of my professional career is all based on helping to develop and then leverage these tools. So I am on like the Cosmos, Epic Cosmos Governing Council. So I'd have that. I'm also on the Trinetics Customer Advisory Board. So really got my fingers, deep in there, but no financial connections. So the talk is really broken up into three pieces. Spend a brief amount of time sort of talking about introduction and background to sort of frame how I got into this space and some of the important things for you to think about if you want to get into this space. use an example of a pediatric hypertension, and then hopefully spend, probably about half the talk then on really getting down into these tools, Cosmos and Trinetics. So I always love asking this question to different audiences, and this will be, a chance for audience participation. So this is a quote I heard, and by the time I get to the end of the quote, I'd like people to, I guess, either in the chat or in the room, what is XXXX, right? So by the year XXXX, 90% of clinical decisions will be supported by accurate, timely, up-to-date clinical information and will reflect the best available evidence on what works for whom and under what circumstances. So any idea what XXXX is?
1995.
Okay, so I'm seeing the chat here. Okay, so first of all, there's a dichotomy. Some people think we've already gotten there. Maybe we've been there for a couple decades. Some people think 2030, 2035. Right. So just to give you background, 1965. Okay. So just to give you background, so I was at an Institute of Medicine meeting in 2010. Right. And they were saying by 2020, right? So we're going to work really hard in the decade from 2010 to 2020, and hopefully we'll get there by 2020. I would say, I'm a practicing internist and pediatrician. I do not think we're there in we didn't get there by 2020. I don't think we're there in 2026. 2030 seems a bit optimistic to me. I don't know when it will be. And I would even argue, I hate the 90%, right? If I'm a patient or my family is a patient, I want that to be 100%. And the reason I sort of start with a question like this or this sort of framing is, I think electronic health records are going to be key to helping us get there and accelerating the pace with which we can get there, really in two ways. First of all, through the real world data that increasingly is captured as part of normal clinical care, it's going to help us make discoveries that are going to get us to that or 100%. That's one. And then two, as a primary care provider, but also a leader that's trying to help with quality, process improvement, there are so many things that we know to do now that we can't do or don't do in routine clinical care, where I think the electronic health record really can be used as a much better tool to get the evidence that we know we should be delivering today to get it to 100% of patients. One of the sessions I was in this morning, I was hearing that, the hyperbilirubinemia guidelines for children that came out several years ago, there's a study that showed that only 25% of newborn nurseries are using them today, even though these new guidelines have been out for years. So there's both the discovery part where I think electronic health records can help, but then there's also making sure that all of that is implemented into practice. To me, all of us aspire to be learning healthcare systems more. So, I just point out the Learning Healthcare System Institute of Medicine report from 2012. But 7 of the 12 characteristics that they talk about, clinical decision support, universal electronic health records, tools for database linkage, mining, and use, they're really core to thinking about the electronic health record. Public engagement, new clinical research paradigm, which is what these tools like Trinetics and Cosmos are giving us. Notion of clinical data as a public good, and incentives aligned for practice-based evidence and getting that delivered and integrated into patient care. Don't want to do a whole history lesson here, but I think history is important to understand where we are today. So I just want to give one slide talking about the American Recovery and Reinvestment Act. At least to me, as an informaticist, this was key piece of legislation because, if you look at this, now I'll just jump to the next slide here. Before that, in 2010, electronic health records have been around for decades. Like the Epic Corporation just celebrated its 50th anniversary. But what's happening, up until the late 2000s is that, under 20% of practices, either ambulatory practices or hospitals, had electronic health records. And then because of the tens of billions of dollars in meaningful use stimulus through the American Recovery and Reinvestment Act, you saw this huge uptick basically from 2010 to 2014, basically getting to, hospitals were at the high 90% of all hospitals have electronic health records. And then in ambulatory office-based practices, it's, you know, lower 80%. And this is important if you're going to use electronic health records for research, right? Because it means you really want to be skeptical, in my mind, of data before, say, 2014, 2015, because you just know that, you know, there's something different about the systems that were contributing data because most systems were not contributing data. Just to give you some perspective for Metro, so Metro Health is the public or safety net healthcare system in Cleveland, Ohio, where I've been for several decades. We're academically affiliated with Case Western Reserve University, and you know, we've had a long Epic journey, which was one of the reasons that, you know, I think sort of put us to be a leader in this space. So, you know, we actually started to install Epic back in 1999. Just think and pause, like, what were you doing in 1999? I asked this question to someone I was working with a couple days ago. She's like, I wasn't even born in 1999. So, you know, we were going back a long way, but we had this visionary CEO at the time that really thought where the puck is going is with electronic health records, and so how to install it into Epic. I think it's also important just a little bit to know about our healthcare system because it sort of gives you a sense of the native data that we have. So we're academic medical center. You can see big teaching hospital, our Epic journey there on the left, a lot of data, which is important just in the Metro Health system. And then, you know, we're really the first public or safety net healthcare system to ever install Epic, starting first go live in 1999. And we've sort of achieved a number of accolades in terms of our use of electronic health records after that. Okay, so now I want to talk to you about my first foray into big data, and it had to do with pediatric hypertension. And most of these things I talk about, they'll have references if you want to look at the you know, sort of the full article. So this was, you know, can we use data, clinical research informatics, whatever, you know, moniker you want to use, to identify and prove misdiagnoses based on isolated clinical observations related to guidelines. So the way this story unfolded, so right after being a chief resident, I was medical director for our pediatric weight management program. And here I'm using 3 kids using their pictures with their permission. They look nothing like this now because these pictures are from almost 20 years ago. But I would see these children in the pediatric weight management program. And, you know, being that new attending, I really wanted to look at the data on these individual patients. And what I start to see is, well, you know, yes, you'd come to see me for a weight problem, but I also look to see if they had a blood pressure problem. And, you know, many of these children, I would say, usually telling the parents and the child, you know, not only does your child have a weight problem that we want to deal with, but looks like your child has a blood pressure problem too. We've got lots of blood pressure sitting in the electronic health record, and we've got more than 3 in the abnormal range. So, you know, your child has pediatric hypertension as well. And then the way the discussion would go is usually the parents would be taken aback and they would say, wow, you know, I had no idea that a child, I mean, my child's only 10 years old, 12, 8. How is it really possible that they could have pediatric hypertension? And then they would quickly go to, like, and why are you the first pediatrician that's told me this? Like, I've got lots of pediatric care, you know, in the Metro Health system. In fact, it was a pediatrician that referred me to the weight management program. But none of them ever mentioned anything about the pediatric hypertension. So why are you telling me this? Well, I was taking the time to look at the data that was just sitting in the electronic health record. So this isn't meant to be a whole definition or, you know, the discussion about pediatric hypertension, but I think the definition is a little bit helpful. And in fairness, these are the definitions in place in 2007, 2008. So for anybody that deals with hypertension, they've changed a little over the decades. But the key here is that, you know, it's still like normal and then, you know, pre-hypertensive, stage 1, stage 2. But for adults, it's absolute numbers, which are easy. You know, most, you know, 3rd, 4th year medical school students can remember those numbers. On the pediatric side, even though there's still 4 categories, it's all based on percentiles, which are then based on like the height percentile. So, you know, I haven't run into a pediatrician yet, including myself, that can remember the hundreds or thousands of data points that you need to remember to figure out if, you know, for a 9-year-old at the 75th percentile for height, is her blood pressure of 100/50, is that normal or abnormal? Now, the good news about this is, it's easy for a computer to do that, right? A computer to number crunch is a simple thing. And then you need at least three measurements over time. So what I did then, I started having these isolated clinical observations. And then I asked the question, could this be part of something bigger? So, in our system, I don't know what the system's like here, but on our intranet, there was a button, and the button said, request data. And so, I was just a junior attending at the time. Wow, this sounds like a really powerful button. So, press the button, and it's me like, oh, you need an IRB. Okay, so now I go through this whole IRB process. Then I got the IRB. Okay, now you can put in your data request. So putting the data request, it gets into this long queue, right? So 3, 4, 5 months later, I get this set of comma-separated variable data. So, I had some statistical, background. So I'm like, okay, now I've got this huge, at the time, 15,000 patients worth of data. And now I got to crunch all the numbers. So, it went from, me having this clinical observation. I mean, it was like about a year later until we could actually submit the manuscript for publication. And, myself, and I worked with 2 other medical students, like we'd spent like lots and lots of time doing the IRB, submitting the data request, sort of crunching all the data. And so through that, it really pointed to me, one, there's huge opportunity with electronic health record data, but there are also huge sort of bumps or hurdles that need to be gotten over to get to that data and use it to follow up on a clinical observation that I had. So this study ended up being published in JAMA at the time, basically showing that, data sitting in the electronic health record, showing that a child had hypertension. Only about a quarter of the time had it been diagnosed for hypertension. Only about 10% of the time had it been diagnosed for prehypertension. This was recognized as one of the top 10 breakthroughs in all of stroke and cardiovascular medicine by the American Heart Association in 2007 and won a Ladies' Home Journal Healthcare Breakthrough Award. But what I like the most about this is I did a lot of speaking about this. This is now 15 years ago. A pediatrician, when I was presenting this at CHOP, Children's Hospital of Philadelphia, said, it's like you discovered the Post-it note, right? So anybody that takes care of kids, particularly in primary care, if you start talking about this, they're thinking, wow, do I have underdiagnosed children, in my clinic, based on this? But one of the reasons I like sort of, talking about this story with a Post-it note is I think there are actually thousands or maybe tens of thousands of Post-it notes to be found in electronic health record data, right? And the idea of a Post-it note is it's such an obvious thing to invent or to use once you see that someone else has invented it or discovered it. So think about the Post-it notes in your own field. Now this had a lot of sort of legs to it. One of the things that happened, and I actually got a lot of criticism by my colleagues initially, because they said, you're pointing out how bad we are as pediatricians. I said, I'm just pointing what the data shows. And my guess is we are no better or no worse than pediatricians anywhere else. The problem is I don't have data for anybody else. All I have is my own data. So then one of the offshoots of this is I worked with the American Academy of Pediatrics to create this thing called clinical effectiveness research through combined electronic health records, or CER squared, where now we got data. And again, just to give you a sense of this, this was a grant. We had millions of dollars where we had to get data use agreements, combine data from people that took a couple of years. And we redid the analysis now, not just with our one site, but now we had 222 practices across 27 states, representing 1.4 million children. So I went from 14,000, now I'm at 1.4 million. I thought that was big data. And what happened? Well, we basically found the same thing. And actually, if you look at this, in this cohort, the clinical diagnosis was like literally even lower than what we found at Metro Health. So actually, when Metro Health data was combined with others, we saw that Metro Health people were actually doing a little bit better, even though everybody was still not doing so well. And then the other reason I really want to point this out is thinking about big data. One of the questions, so as a med-peds physician, I know that in adult hypertension, there are very clear guidelines of what medications to use and what types of patients and how that should be prioritized. In pediatrics, there's no such guidelines. Why are there no such guidelines? Because there is, quote unquote, no evidence. Why is there no evidence? Because nobody has a large enough population to study. So if you just think about this, what I'm showing there, if you look at that medication, 190, so I had to start with 1.4 million children to identify 190 children that had pediatric hypertension that were on a medication. So this ended up being really like the first study ever. Now, we weren't trying to prioritize, we were just looking at what's the natural history of what antihypertensives are being prescribed to children with diagnosed hypertension who people decide to prescribe medication. So I think, again, the other huge research opportunity for these data tools is, especially when we get to some of these bigger ones, is the idea, as I was telling someone this morning, if something only happens 1 in a million times, but you start with 130 million or 300 million patients, you're going to have a bunch of patients, even in something that's very, very rare. I just want to spend a little bit of time going on the idea that, not only can electronic health record data be used for scholarly activity, but there's also an opportunity for intervention, right? So I've done a bunch of research over the last 15 years or so that said, it's great that we identified this huge problem. What have I done to try to solve the problem? So we've done things like, making sure that the blood pressure percentiles can be integrated into Epic. So it's very easy for a pediatric provider to see what the percentile is. We've done things like have alerts that say, hey, do you know that this blood pressure that was just taken today is high? And actually, there were other high ones as well. So this child does meet criteria for pediatric hypertension. And these are all the things that should be done. So we've had best practice advisors, or now Epic calls them our practice advisors. We built in, order sets and prior data, doing a lot of things to try to alert people to this idea of pediatric hypertension and trying to follow those best practice guidelines, right? Because I want to try to get, at least for pediatric hypertension, at least to that 90%, right? If not the 100% of people with that disease, they're getting the best, most up-to-date, timely care that they can be. And when we looked at all this, we basically found that in our system, we've been able to go from only about a 25% recognition to up to about a 58% recognition. And again, I always tell my team, I'm the glass half full person, not the glass half empty. But on some level, this is great. We doubled the recognition and presumably appropriate intervention with pediatric hypertension in the Metro Health system. Although again, 58% is nowhere near 90% and certainly not close to 100%. Okay. So I thought hopefully that's a good example to sort of frame the milieu that I was working in then, now thinking about these aggregated electronic health record tools. And again, just to broaden, again, I think there's 2 ways to use electronic health records for scientific discovery. One is using the electronic health record to improve care, on the left there. I won't talk anything more about that besides what I did with pediatric hypertension, but I think there's a lot of things to do in that bucket on the left in terms of whether you call it operational research, quality improvement, things that are already happening in the healthcare system that you can just spend a little bit more time evaluating and some more time disseminating, and you can get abstracts and publications on that. But what I'll spend all my time for the rest of the talk is on the right-hand side, your right-hand side. Let's solve this problem by using big data. None of us have the slightest idea what to do with. Hopefully in the next half hour or so, I'll convince you that, I have some idea of what to do with it, and I can impart some of that information to you so you'll have an idea what to do with that as well. So data is power. Again, I think that to me, this is just with the electronic health records and meaningful use, there's no generation like now where this really is true. So let's get into some of the details here. So we have this idea of, at least since 2014, in some cases, longer than that, we've been collecting electronic health record data for regular clinical care. No idea of research or scholarly activity, quality improvement, just for regular routine care. And now, since we've had the electronic health records, this data can be aggregated together. So you can start to get tens and hundreds of millions of patients worth of data, literally billions and billions of data points. Now, it's real world data. Data collected as part of messy real world clinical care, not specifically for any sort of quality research, anything like that. So, classic example, how many of you ever seen like a pediatric growth chart that goes zzz, right? Where, probably somebody did pounds instead of kilograms, or, who knows, fat finger, who knows what was going on. So, disadvantage of real world data is it's real world data. We know there are going to be errors in it. I would counter by saying the advantage sometimes of real world data, it gives you a much better sense of what's going on, right? To have a data set that's been highly curated on a very, very small set of patients, I think sometimes it's hard to understand how generalizable. I mean, it may be true for the data and that finding in that population, but how generalizable is that? Because we know that, most data is not collected in a pristine way, and there's generally just a subset of people that even participate in clinical research, which might not represent the people that you're trying to study that don't participate in the clinical research. And then I would say, although there's a lot of informatics opportunities here, I'd say at this point, these tools really focus on the structured data, and we'll get more into that. But so far, I would say a lot of things that are put into the notes of a chart, they're really hard to get at through these data tools today. But it's a volume and variety of data that literally have never existed in the history of the world. So some of the high level sort of things to think about, again, I alluded to it before, but I think you can't look back at things much more than 2014, 2015, just because of the adoption. The other sort of caveats I say is I think it's much easier and I have more confidence when we're using these tools to look at outpatient, what I call outpatient, as opposed to ED or inpatient questions. And the reason I say that is I think data collection in the outpatient is more standard, and the data density is less. And I would say, a lot of these platforms, especially now, they don't do a good job of sort of disambiguating like multiple things that happened in a day. Of course, in an outpatient setting, there usually aren't too many things that happen in a day. But in an ICU setting or in an ED, there can be tons of things that happen to a patient in a day. So 2014, 2015 and greater, and then think about more outpatient type studies than inpatient. Again, these are some generalizations. Sometimes there's exceptions to that. Okay, here's another one opportunity for audience participation. So I love this quote in thinking about this from Thomas Watson. Does anybody know who Thomas Watson was? Okay, that is the most common answer I get. That's not the answer. That was a different Watson. So Thomas Watson was actually the founder of IBM. So, right, so I think some people in the chat got, right? So when you had the Watson computer that won Jeopardy or won chess, right, that was named after him. And so I think if you really want to use these tools well and appropriately, asking the right question is important. And so what I said, so typically what happens in research is I come up with my great research question, and then I try to use any tool or technique that's out there to answer the question. You sort of have to flip that around if you want to use these tools, because I say I'm the first to say that things like Cosmos and Trinetics, there are many, many awesome questions out there that these tools are not going to be able to answer, maybe ever, and certainly not in 2026. So I think if you really want to take the advantage of these tools, first you have to invest some time. And when I say time, it's probably on the order of hours, maybe 10 hours, something like that. It's not months and months and weeks, but you got to invest a little bit of time to try to figure out what are the types of questions, and I'll give you some primers on this. What are the types of questions that these tools are going to be awesome at answering? And then in your scientific field of interest, ask the questions that we already have a good sense that these tools are going to be really good at answering, and knowing that it's a subset of probably all the tools that you want, or excuse me, all the questions that you want to answer in your clinical discipline. So the question is really important. We've published on some of this. I won't, all the references are here, but, if anybody, I know I talked to a bunch of pediatricians this morning, so we did a whole thing on using electronic health records in peds people can look at. We've written this whole paper that probably I would recommend people using Trinetics want to use, because all the examples in this paper are actually from Trinetics. We say with big data comes big responsibility. And I know this is being recorded, but I'm happy to distribute the slides to anybody as well. I see some people writing furiously, so maybe I'll leave this up for another 5 seconds. But basically, we've gone through And a lot of the sort of gotchas, we've tried to sort of preempt, because there are definitely ways that you can go awry in using a tool like Trinetics. And to me, the most important thing is people going awry and they don't know they're going awry. I mean, if you're purposely going awry, then that's on you. But if you don't even understand that you're doing something that you shouldn't be doing, I feel like that's sort of more on us who know about the tools more. So I've got that one. And then this one that just came out in the fall, I've not been involved in this one at all, but this target statement. So this is specifically the use case of when we're trying to use something like Trinetics or Cosmos for target trial emulation studies, which I'd say that's a very growing area type of research. So that's the idea of basically sort of trying to do a prospective randomized control trial, like with an intervention, but using, sort of the retrospective data in something like Cosmos or Trinetics. And what is the opportunity? So I couldn't figure out a better picture to try to talk about the outcomes than this one. So this is, I mean, anybody can check this. This is just my PubMed publications. And so basically what you can see, like my first publication was in 1994. The pediatric hypertension one was in 2007, so I had a little bump up there. But you can see basically for like 2 decades, I was sort of percolating along at, several a year. I was hoping to be able to get to 10 a year. And then I started to understand and use these tools. And my peer-reviewed publications are skyrocketing. I mean, it's literally like the picture's worth 1,000 words there. So over 280. Again, you can see just in these last 2 years, 130 already. I just looked this morning to make sure I got the most up-to-date number. Already 16 in 2026. And basically the way I've been able to do this is, just to give people a sense of this, so I'm like the middle author on these, right? So what's happening? So usually it's a trainee, a medical student, a resident, maybe a junior faculty is like the first author or two. And then usually there's a clinical domain expert in what they don't need to know anything about Trinetics, but they're an expert in their clinical domain. 1 or 2 of them is at the last authors. And I'm sort of in the middle helping, the catalyst for all this. So this, I feel like this slide is so important that I've included it in the deck twice. So what I'm doing here is, from my experience, literally over, hundreds of articles now, trying to sort of say, regardless of what your scientific discipline is that these are the types of studies that these tools are really, really good for. Doesn't mean there couldn't be other types of studies, but sometimes people just try to ask studies, again, that it's not the right question type of thing. So let me just review these. So simple associations, and again, these are all published references. You can look at the individual studies, and there's lots more if you PubMed me. So simple association. So I'll come back to this one later, but about 2 years ago, with all of this proliferation of GL1 prescribing, there was concern of, wow, it seems like some people prescribed GLP-1 are then trying to commit suicide. So could it be an association where GLP-1s are actually increasing suicide or suicidal ideation? Big concern. And basically, we very quickly analyzed that question. I'll save the answer for a little bit later. Second one was healthcare utilization. So this was actually done using Cosmos, where when Paxlovid, the first COVID-19 sort of treatment, came out. We just looked at how is it being prescribed, and we saw that for better or for worse, I would say for worse, if you were white, you're more likely to be prescribed Paxlovid than if you weren't white. Guideline compliance. I mean, there's the pediatric hypertension one, but the nice thing about guidelines is most specialties have guidelines these days. So I think people want to know, among a very, very large population, how well are these guidelines being followed? And of course, everybody hopes that their guidelines being followed 100%, right? Like my slide from the Institute of Medicine. I've never run into a guideline yet that's been followed 100% of the time. And so it's interesting. People want to know: is it 56%? Is it 20%? Is it 73%? And are there patient-related factors that might, impact how well the guidelines being followed? Descriptive studies in small or large populations. So I've mentioned to a couple people this morning, this study on Treacher-Collins syndrome patients with now Dr. Kloss. She was a medical student at the time. And I think, the main reason it was published is because people said, what? 1,114 patient with Treacher-Collins syndrome? Like, we didn't know that many people existed, right? But again, 1 in a million times, 130, 300 million, you get a lot. And then sometimes just even for population and chronic disease surveillance, you can track, things over specific time periods and see how things are trending. So, and again, not going back more than 10 years and more outpatient focused, but I would preface, I would think for any area of clinical study, probably there are, 1, 2, 3, 4, or 5 domains where these tools could be leveraged. I think it's important to have what I call 3 legs of the stool. And again, I have a lot of medical. We have over 900 users of Trinetics, at Metro Health. A lot of them, I'd say, literally, are probably hundreds of students. And I always tell the student, so we need the researcher or the student. So this is someone with the fingers on the keyboard in Trinetics. Again, this picture I'm using Verno Lacker, who's one of my students. She personally, I think, has 7 first author Trinetics publications now. Definitely have to have the clinical domain expert who, again, doesn't need to know anything about the tools, but needs to really be an expert in whatever area of clinical research is being done. And then you need to have that informaticist, data scientist, someone who understands the underlying data, maybe a little bit of statistical knowledge. Again, sort of trying to keep some guardrails on the tool so that, we're sort of not going off the rails, so to speak. And this gets back a little bit to my own experience as a researcher, but then as the chief health informatics officer, where, I really wanted to get us to a platform. Why? Because, this scenario happened to me scores of times where someone would come to me, a medical student, someone else, and basically say, hey, like I have this amazing idea for a research project, but I need some help obtaining data. Can you help me obtain data? And of course, being the person I am, oh, of course, I would love to help you obtain data. Oh, you want patient data? Okay, now we got to do the IRB. So that would be a 2 to 3 month odyssey. Then they would come back, okay, now I know a little bit more. I need the IRB. Can you help me with the IRB? Oh, of course, happy to help you with the IRB. Go off and do that. Dr. Kaelber, now that I have the IRB and my data, can you help me analyze the data? And again, this just takes months and months and months. And then, I'm sort of asking, like, well, what's the medical student really doing in this model? So, data can be labor intensive to obtain and decipher, may have privacy issues, and then still needs to be analyzed. So a platform, on top of the data solves many of those issues. And so now I'll get into some of the details of these platforms. So, this top row, this is the model that I just sort of in the cartoon with the medical student, or for my pediatric hypertension, that's what we're doing. So I was manually requesting line level EHR data. Basically, at least in our environment, always needs IRB approval. There's no built-in analytics, so you have to do the analytics. It's only one site. Our site happened to have 1.6 million patients. I think all the sites here with Epic have slicer dicer, so that's meant to be a self-service tool where you generally don't need IRB. Again, if you're just looking at population level data, still it doesn't have analytics. It just gives you counts. Still only one site, and then you still got your same number of patients at your one site. Now we're bringing in Cosmos, and again, if people are very familiar with this, I'm really focused on Cosmos Slicer Dicer, not so much Cosmos Research Data Sciences, because to get to Cosmos Research Data Sciences, I'm happy to dig down more on the question. You need a very high skill set, so it's not going to be accessible to many people unless they have a team that have people with the skill set. You have to know the Epic data model really well, which is a big learning curve, and then you have to do special training with Epic to get into this separate environment that they have. So if you're just using Cosmos Slicer Dicer, no IRB needed, still built-in analytics, many more sites, so greater than 225 sites, 290 million patients. And then we have Trinetics. So Trinetics, it is a privately funded company focused on CTSC and academic medical centers. No IRB needed. It has built-in analytics. We'll talk about that. That is a huge game changer for learners or early career people. Number of sites and a large number of patients. I'll also, again, I won't go into this a ton, but someone for another talk had asked me to put in this. So I don't know if people use things like PecorNet or Enact or some of these other things. I don't consider myself to be an expert on ENACT, but I sort of tried to do sort of like head-to-head comparisons of, why you'd want to use, one versus the other. So again, I won't go into a lot of it unless someone has questions in the Q&A, but it's in the slides. So just if people aren't familiar with these tools, my sense is there's sort of a heterogeneous audience here. So this is a Slicer Dicer. This is just from the Metro Health Slicer Dicer. So it's meant to be a self-service querying tool. There are a ton of data models, which I find everybody seems to focus on the patient data model, which is great, but there's a lot of really novel patient models that you can do different things like if you want to look at alerting or just how the lab is doing or how people are ignoring or not ignoring alerts. So there's a lot of things there. Even though it's just a querying tool, you can look at the data in lots of different ways, line graphs, bar graphs, tree maps, donut graphs, pie charts, geomapping down to really zip code, in some cases census block or census tract. So that has some really interesting implications. The size of Cosmos, I think we know about the size of Cosmos. A whole bunch of data networks. I think one of the most fascinating ones is the patients with birthing parent information. Again, I don't know any other source like that, so that's nice. We publish, if anybody wants to know more about how you can publish with Cosmos. So we did the first Cosmos publication ever, basically showing how you could replicate some other studies, but also talking about sort of how Cosmos works. We're actually just getting ready. It's been approved by Applied Clinical Informatics. We're going to do a second Cosmos publication. It won't be the second one ever because lots of people are publishing, but it really updates the infrastructure of Cosmos. We've worked on it with the Epic Corporation, so that should be coming out probably by the summer. This is just a study with a medical school student where we're looking at COVID vaccines versus COVID in terms of myocarditis. And this one is also just done using Cosmos Slicer Dicer. Now, again, we didn't publish this. This was just sent to, AAP national meeting, but won like the Outstanding Poster Award. So lots of things you can do. And then Trinetics. Again, I think you know some about that to varying degrees. This just gives you some sense of, there are different networks in Trinetics, which it's hard to explain probably in this venue, but, well over 100 million patients. You can see all sorts of demographic information. This gives you some sense of what is that structured data. I said I was going to come back to the structured data. So you have demographic information. So that's like age, gender, race, ethnicity, a diagnosis. So think, ICD codes, procedures. So think CPT codes, both E&M and sort of true procedure codes, medication. So again, everybody is using computerized physician order entry. So the medication prescribing information is awesome in Trinetics. Now, anything that you say in this room will stay in this room. How many of you have ever not taken a prescription exactly how your doctor prescribed it to you? Right? Okay. One honest person among the group. So again, it's really good for what's prescribed. You don't really know what people took it, although you can look at multiple prescriptions and some, there are sort of tricks to use here. Lab data is in there, all the results. You can, stratify it like as different types of variables. There's genomic information, but a lot of people don't have genomic information. But it really gets to the problems with my hypertension data and the lead study and the medical student experience where there's no IRB. There's no analytic, there's no extra analytics that's needed. It's all built in there. They have built-in training. I sort of showed that in the middle of the right-hand side there. Different data sets, different features and functions are on the analytics. So a lot of things that, we can take a medical school student, have them do 4, 5, 6 hours of training, then they know how to use the tool, still got to ask the right questions, so need some mentorship around that. This gives you some sense of what the training looks like. I'd say Trinetics has very extensive and robust online training, sort of all self-service modules that can be done. Some places require certain modules to be done, in conjunction with giving access. We know a lot about this because we're the largest Trinetics user in the world. We're always jockeying with the Trinetics Corporation of sort of who's going to be doing more queries in a month. But again, happy to share the experience more with folks. I'll just come back to this study. So this is the one I was alluding to before with semaglutide and suicidal ideation, sort of the simple association example. So we actually worked on this with William Wang, who at the time was a high school student. Now he's an undergrad at Stanford. Again, just gives you a sense of how easy it is to sort of upskill people with this. So there were these isolated findings of GLP-1s increasing suicidal ideation. But, these are being prescribed so much. I mean, some of those people are also going to sprain their ankle. They're going to get a cold. They're going to do other things. They're going to have back pain. Doesn't mean that the drug was causing this. So we're pretty quickly able to look in both for diabetic patients and for the indication of obesity, and basically show that there was no disproportionate association between prescribing the GLP-1 and the suicidal ideation. Whether it be incident suicidal ideation or sort of recurrent suicidal ideation. This got a ton of press in like January, February of 2025. So, Washington Post, New York Times, CNN, you can see all of them there. And then what I was most excited about is 1 week later, the FDA came out with a paper saying, don't worry about this anymore, right? We think there's not an issue there. And then the European FDA equivalent about 6 months later also came out with the same statement, citing this study as one of the major reasons for their assessment. So again, not only are we're answering a scientific question, but seems to have some public policy implications. So I said this slide was so important, I was going to show it twice. So here it is again, just talking about the types of studies that can be done. Either using, in general, Trinetics or Cosmos, but sort of using that real world data. And so to me, again, you've spent almost 60 minutes here. So what are you going to remember from this? Hopefully the three-legged stool is an important key. The asking the right question, think about Mr. Watson. Try to see how you can leverage, these data platforms like Cosmos and Trinetics, because it just greatly decreases the resource that's needed. Lean on local resources. I know there are local resources there. I talked to some this morning to access and help with these tools, but I also love to develop partnerships with people. And I don't know if you know the picture in the lower left-hand corner, that's the Nobel Prize. I'm not going to promise a Nobel Prize, but I think you can do some amazing research. Present nationally like Jane did, or publish like William, the high school student. I just show again that little picture of my own publication trajectory, and feel free to contact me. There's my contact information. Love to have some lasting connections from my visit to Nebraska. With that, thank you very much for the time.
At least one question, or somebody had a question.
So maybe just to help me understand these platforms a little bit better, how'd you get suicidal ideation from Trinetics?
Right, so that would be an ICD code.
Okay.
And so again, how good is the ICD code for suicidal ideation, for real suicidal ideation? I mean, I don't know what your background, you can judge it like, is it perfect? Absolutely not. If someone has significant suicidal ideation, they're probably coming to the emergency department, and that's probably their chief complaint. And so it's probably going to be coded like that. The other thing I would say, again, think about what we're doing. Both the intervention group and the control group are both in Trinetics, right? So the other, and I agree, it's a little bit of bootstrapping here, but the real question you want to be asking is, do you expect suicidal ideation as documented by ICD coding for people prescribed GLP-1s, right, is going to be materially different in its messiness than people not prescribed GLP-1s? And I think most people would say, well, it's not going to be that good in either one. It's not going to be perfect in either one, but I wouldn't know why it would be better or worse in one versus the other.
And a general question is, you said earlier that it's better for outpatient versus inpatient, and we see a lot of folks, residents, doing national inpatient sample studies similar to these questions here. Can you sort of remind us again why you would recommend it more for outpatient versus inpatient?
Yeah, two main reasons. One is sort of the quality of the data. So just as an example, I do some inpatient attending. Lots of times people don't code anything except the initial, admitting diagnosis. And then a lot of things are put into flow sheets or other things that are not captured in these tools. So I think just the way that inpatient care occurs, I think you're much less likely to get the data exported into these tools. And then the other piece is, depending on what you're looking at, is that, again, something like Slice or Dice or Cosmos really can't distinguish things that happen within a particular day, right? So if someone has like 3 CBCs in a day, you're not going to be able to figure it out with the platform. Like, well, did it go up or did it go down? So it's that data density that occurs in an inpatient setting would be the other main issue. Yeah, that'd be great because I just got back on. Go ahead.
What are components we can extract from Cosmos, like scope reports, pathology report labs?
Yeah, so the basic lab data in Cosmos and I'll just say TriNetX is great because that's all discrete. Things that occur in reports, so radiology reports, pathology reports, endoscopy reports. Today, a report is a text blob, right? And so basically there's no data that can be gleaned from any of these reports. Now, I'll just say both TriNetX and Epic, they're aggressively working on that. And, but I would say, I've been in informatics for 25 years now, and natural language processing was always something that was going to be great next year. It's still something that's going to be great next year. A lot of people are working on it. I think we'll make progress, but today you can't look at it. You can't distinguish any of that data in those tools.
Yeah.
Oh, it wasn't an NLP. Yeah, I mean, I will say, and I don't know if you guys have done, I mean, we're an alpha tester with TriNetX. TriNetX just released this idea that you can type in words that can then be free text search within your own institution. So I don't know if that's part of your contract or not, but that's starting to get at that. And they do have the idea of radiology reports, operative reports, pathology reports. So it's coming. It's going to be slow. Yeah.
Yeah, thanks for a great talk. It always surprises me using real world data, the little quirks in each data set or at each institution versus the other. So do you have any guidance about when you use this large aggregated data, how we make sure there's no funny little quirks to one of the sites, or do we just hope that we have big enough data that any little quirk is just going to be a tiny bit of noise?
Yeah. So again, for better or for worse, it is that you'll have no idea. I mean, you won't be able to see any of the quirks because part of the de-identification is not only patient level de-identification, but really site level de-identification. So you really, part of it you have to take on faith. And then again, I'm not trying to whitewash it, but there is this idea, the data is big enough that probably any one site's problem with their data hopefully is not affecting your, output. And the other thing I always tell people, I've done a lot of research with these tools, and we're talking I'll say this here, like I never really believe the quantitative result, right? I believe the qualitative result, right? And that even gets to like these tools are real time, right? So if I run a query today and then do the exact same query a week from now, I will probably get a different quantitative result. Qualitative results should still be the same, otherwise something like really weird is happening. But you have to sort of think about that. That's great.
This may be along similar lines. We've been asked, can you talk a bit about data quality / bias issue overall? Did you ever face it in your research, and how did you approach?
Yeah, so I would say, both TriNetX and Cosmos, they try to do data checking when it's coming in. I'd say Cosmos is good about trying to be transparent about that. So if you know where to look onto Cosmos, you can see completeness not only at your own site, but sort of completeness across the network. You can see some of their quality checking. TriNetX just doesn't have that sort of transparency to it. I'd say even when you can see it, it's never materially sort of changed what I do with it. So I guess I'm trying to be responsive to the question, but it's an issue. I think what most people are hoping is that it's sort of big enough and the companies are doing a good enough job that as a researcher, it's not something that I spend a lot of time on. But I guess, some of the big caveats, right? I mean, all of this should be biological plausibility hypothesis driven, right? You should not just be poking around and seeing if you can get a p-value that's significant. That's one. I always talk about, I don't say data validation, but sort of data or results corroboration. So one time, I had this, again, you've probably been in these situations, the student said, oh, I worked on this, I found a result that's different than every single other person in this field has published on. Isn't this amazing? I said, well, yeah, it could be amazing, or it could be you just did it wrong, right? And I'm much more in the camp of you probably did it wrong than you were the first researcher to ever figure this out amongst all these other researchers, right? And so then we work with that person. So I think there just has to be sort of the sanity check too of, does it make sense? And whatever question you're answering is probably not in isolation. There's probably other people might not have used the same tool, but you're sort of building on this mountain of research, and does your finding seem to fit in with the mountain? So that's sort of a type of quality checking all those at the end. Yes.
David, I was gonna get you off the hook. And so want to thank everyone online for joining us today, and thank David for a wonderful talk. And apologies for the technical issues we had during your talk. It's just not a talk if you don't have problems with IT. So but want to thank you for visiting with us. And I think this has a lot of people thinking about how they can use these resources. So thank you.
Excellent. What's the one thing you're going to do differently? Thank you very much for your time.